PFIC and the surgical management of it, I really mean that there's two thoughts. One of them is that you have to manage the complications of cholestasis, and what I mean by cholestasis is the itching, the yellowness, and the jaundice of patients that have PFIC. And it's not, as Dr. Squires said, it's many different diseases all in one. But one of the common factors is the itch, and so there are surgical options to treat that. And then the other side of surgery is kind of the management of complications of progressive liver disease, and that would be transplant. And so I put the talk really into two sections. The first section is kind of surgical management, non-transplant surgical management of the cholestasis, and the second part of the talk is transplant. And I do have a lot of stuff that we can talk about that kind of goes into tomorrow, and kind of the second part of this, which is specific transplant issues in patients with different types of PFIC. But long story short, the status of the liver and the symptom that is being treated obviously determines the type of surgical intervention here. And so the liver really dictates what we'll do. And so the surgical management of the cholestasis is really reserved for patients who failed conventional medical therapies for the cholestasis, and in many ways have failed medical therapies for pruritus. And so the surgical treatment really requires that pre-existing damage to the liver is not severe, and it's kind of in that middle area that Dr. Squires discussed. It goes from normal liver to kind of end-stage liver disease and cirrhosis, to safely perform surgery to ameliorate kind of the itching, to do non-transplant surgery in these patients. You really need a liver that is relatively healthy. And so what are the transplant surgical options for patients, and why do they work? This is and where did it come from, really? And so this is a picture that's been around. I think it's in about 3,000 different medical texts, but this is called the enterohepatic circulation. And Dr. Squires, we talk a lot about this, as nerdy as we are, and talk a lot about how things are absorbed. And it's very important to realize that bile salts are one of the major problems in patients that have PFIC. And one of the major reasons that they're a problem is that they can't be excreted, or they're poorly excreted or poorly processed by the liver. But it is a common feature to every patient that has PFIC, whether it's PFIC 1, PFIC 2, PFIC 26. It doesn't, all of them have to do with the processing of bile salts. And so bile salts are kind of handled by the liver. Cholesterol kind of joins, and these substances go into the intestine naturally through the bile duct, and they end up in the duodenum, which is the first portion of the intestine. They then go through the entire intestine, and they help with fat absorption. And most of your fat absorption, and conveniently most of your bile salt absorption, happens in the very bottom part of the small intestine in an area called the terminal ileum. There are cells there that Dr. Squires talked about that are specialists at absorbing fat soluble vitamins. They absorb actigol. They absorb all of the fat soluble vitamins and bile salts, and then they're absorbed and they go back to the liver. The bile salts are kind of recirculated back down, and it goes over and over again. And so the problem in PFIC is that the bile salts go into the intestine. The bile salts are absorbed by the intestine. This is a very intense drawing, isn't it? I spent a lot of, you can very, very lifelike. The bile salts get absorbed, and the problem in PFIC is here. And so, again, there's a buildup of bile salts in the liver that likely causes the liver damage associated with PFIC. It causes the jaundice. It causes the pruritus because the bile salts accumulate in the blood. And so they're absorbed by the intestine. They get stuck in the liver. They can't get into the liver, and they basically accumulate in the blood, and they cause itching. On the other side of things, low bile salt levels in the bile cause issues with fat malabsorption. And so patients are with bilers or any of the PFICs are generally on a lot of medications that are fat soluble. And so your vitamin D, vitamin E, vitamin A, and K, all of these things are fat soluble vitamins, and it requires a lot of those to keep even lowish or normal levels in the blood. And so if failure of bile salt processing in the liver leads to the damage and the pruritus, what can we do? And so back in the 80s, and I don't think Dr. Squire has told this story, but transplant was really the only treatment for patients with this end-stage liver disease. And there was really no way besides just giving medicine to help with itching that patients with these diseases could kind of go on or be treated in any way. But there was a patient, a bowel obstruction, and the right physician in the right place at the right time. And so a patient with Byler's, PFIC1, was in the hospital and conveniently for us, but not conveniently for them, had a bowel obstruction. And they placed a tube into that person's stomach, which drained bile from their intestine. And what was noted over time was that with the NG tube, with the nasogastric tube that was draining this, the itching went away. And as soon as that tube and the bowel obstruction got resolved, good for the patient, but the bowel obstruction got resolved and the patient's tube came out and the itching came back. And so was the first thought of maybe there is a way to get rid of the itching by way of getting rid of the bile from the intestine. And so if the bile is not making it to the intestine, maybe we can get rid of a lot of these problems. And so, if we can stop this absorption of the bile salts from the terminal ileum, maybe we can get rid of a lot of the disease. And so there's only a smaller amount of bile salts that are absorbed, and therefore the accumulation in the liver is down. The accumulation in the blood is down, the itching goes away, and the liver damage is hopefully decreased. And so there's many ways to do this. There's many ways to get around this terminal ileum, and so you could drain the bile duct with a tube, and that's what was initially done. And so they put a tube from the nose all the way up into the bile duct, hard to maintain, hard to actually use, and they found that indeed it did work. The next step is to maybe we can connect the gallbladder to the side of the body. And so that is done in many different diseases, but it's the actual direct connection has a lot of long-term problems, but short-term certainly seem to help. The other way to drain the bile out from the gallbladder is to connect the gallbladder to a small piece of bowel and bring it out to the abdominal wall and have it drain into a bag. The other thing that you can do is to drain the bile from the gallbladder instead of out of the body, drain it into the colon. And so you could bypass the ileum. Bile would go from the liver into the gallbladder and then from the gallbladder into the colon and not ever see the ileum. And then the other thing you can do is divert all flow from the ileum. And so you take a piece of the intestine and you put it directly to the colon. And so these are all over the course of years have kind of become the standard different procedures. There's a nice cartoon here of them. And so the partial external biliary diversion is really the oldest and the best studied. And so there's a small piece of intestine, this is A. There's a small piece of intestine here that drains the gallbladder. And so bile comes from the liver, comes down into the bile duct, goes into the gallbladder, and then goes out to the body wall into a bag. The next kind of oldest would be the ileal exclusion, and so instead of flow of intestine fluid and bile salts making it to the ileum, it just goes directly to the colon. And then kind of a newer kind of secondary way to do this is to drain the gallbladder either directly into the colon or with a short piece of intestine to the colon, so it only goes to the colon. And so in all of these, the first one I couldn't put a little circle, but in all of these, bile salts, all of the fat soluble vitamins never hit the ileum, and therefore are dramatically, amount of absorption is dramatically decreased. And so a cartoon of a partial external biliary diversion is here. The bile salts go down. Some bile salts make it to the intestine. Most of them go out through the stoma, and then less bile salts are absorbed. And this is kind of a better cartoon. And again, these are this is by far the best studied. This type of surgical diversion and we'll talk about the studies in a minute or two. This is the one that really is kind of the gold standard to compare to. It's also the gold standard that the IBAT inhibitors and all of the drugs that are being developed kind of compare themselves to in their studies. And so we looked at a multi-center study. And so this is all of the groups, or many of the groups in North America that were performing biliary diversions. Children's Hospital Pittsburgh is just one of them. And so we tried to see the results of this. And so if you look at patients that have PFIC1 or Byler's disease, you can see that there's actually a very good response of bilirubin. And so if you look at PEBD is the partial external biliary diversion. And if you look at patients when they first had this done, their initial bilirubin was 8. And over the course of a year or two, their bilirubin dropped down to kind of the 2 level. Similarly, a lot of the other numbers that you see were normalized. The IE is ileal exclusion, and there's very few of those performed comparatively. And I think the number that pops out into everyone's face is the 734 in the right lower bottom of that. I think a lot of those external ileal exclusions, it can be a one-off number that really skews your results. And I think that is fair to say that that 734 was probably not it shouldn't be included in there. But again, I think that the numbers of ileal exclusions done for these diseases is so low that it's hard to really use them for meaningful data. When you look at the reason that kind of these diversions are done is the pruritus, and so patients are itchy. These are patients that have FIC1, and again, this is multi-center. If you look at them, most of the patients got better. And so preoperatively, most of the patients had severe itching, and this is a classification. There's a really old classification that Dr. Whittington, the guy from the picture, came up with, and really these patients had severe itching. They were mutilating itching. They were on multiple medications that could not that would not really help. And by the end of the study, most of the patients actually improved as far as pruritus goes. Many of them were not. We're still on medications for itching, but the medications were at least effective. And so the conclusion of the multi-center study, it's a multi-center analysis of non-transplant approaches. It's not uniformly successful. They're well tolerated. They do get pruritus and cholestasis improvement. And again, this was primarily geared toward patients that have Byler's or PFIC1. When you look at the different types of PFIC that were studied, well, there are 18 patients in this study that were PFIC2 or BSEP disease. And when you look at that group, the results really weren't as satisfying. And so the bilirubin, although it did not start that high, really didn't change much. And the pruritus, again, is similar to that. The pruritus didn't really change too much. And so if you look at BSEP disease, that's PFIC2 on the right. And again, I'm with Jim. I have a hard time even keeping track of PFIC1, PFIC2, PFIC3, and I get scared as more get added. So I would tend to call it FIC1 and BSEP disease. But as you can see, the patients that came in, although their itch was better controlled, it wasn't as reliably controlled as patients that have PFIC1. And the graph itself is a little bit misleading. The numbers in that graph are actually the numbers of patients that were scored. And so you can see, for the BSEP disease, 5 patients had severe itching, 5 patients had moderate itching when the study was started. By the end of the study, only 5 patients responded instead of 10. And so it's hard to tell meaningfully what these numbers mean. But even with that, I would say that the results of biliary diversion, external, internal, regardless of the type, is a little less predictable when you move away from patients that have PFIC1. And then when you look at the need for eventual transplant in patients with these diseases, many patients needed a transplant that had PFIC2 or BSEP disease. And so the results there were not as promising as patients that had PFIC-1. Unfortunately, there is a limitation of a retrospective multi-center data, multi-center study, and the reason the patients were transplanted was not really included. I'm part of the study, which makes it embarrassing to say it, but the reasons for the transplant were not included, nor was the time from the diversion to transplant. And again, it's just the nature of a retrospective multi-center. One patient did die during the follow-up period, and again, it wasn't recorded, but we can discuss that in a little bit. We did a study here at Children's, which only looked at patients that had PFIC-1, and so this was a study of 8 of our biliary diversions. These were all partial external biliary diversions. We didn't do any internal diversions. We didn't do any type of ileal exclusions, and so we tried to keep the data at least as pure as possible. And again, the patients were, most of them even had the same mutation. And so it's a very homogeneous study group, which is nice. What can be seen and what we saw was that patients with PFIC-1 have dramatically low weights, and they have z-scores, which are essentially statistical ways to say that that you have an issue with weight. And there's different types of z-scores, but their weight z-score was quite low. That improved after biliary diversion, and so patients pretty reliably gain weight after diversion. And there is a little bit of a complicating factor in that patients after they're diverted do have a little bit more intense medical treatment than prior, at least initially. But the weight gain that is there is certainly prolonged, and it's over the course of years, not weeks. And I think that it's real weight gain. And so patients do tend to gain weight after a biliary diversion for PFIC-1. The bilirubin normalizes, and so it's pretty reliable that the biliary diversions will drop the bilirubin, if not to normal, to near normal levels. And so what about the itch? So the itch, when you look at it, and this is kind of the supplemental data regarding disease progression, but the itch, when you look at it, patients came in with such severe itching with bilers that they were on multiple medications, and all of them were severe. And so all of the patients in our cohort were self-mutilating despite more than 2 medications for itch. And so by the end of the study, all of the patients were moderate to no itch. And so the itch reliably resolved with patients with PFIC-1. And again, very homogeneous. This is a single mutation. Almost all of them had the one mutation, but the overall experience with itch with biliary diversion is good. And I would say that what we talk to the families about is about 80 to 85% of the patients have a resolution of their itch to the level where they can be down to 1 medication. And so that is kind of the surgical side of pruritus for PFIC-1. What about disease progression? Does biliary diversion prevent patients with bilers with PFIC-1 from developing liver disease? And I think the results are a bit early. I think that it's we have good follow-up. We have years of follow-up, but I think that the risk of developing severe liver disease with PFIC-1 is relatively slow to begin with. And many transplants in the past had been done with some liver disease, but it's very difficult to show biopsy-proven cirrhosis, biopsy-proven liver failure in patients that had bilers that were transplanted, say, 10 years ago, prior to the popular, prior to kind of the building of data on biliary diversion. And so most patients got their transplant for severe pruritus and liver disease. But now with the pruritus being kind of ameliorated with biliary diversion, how many patients will actually need a transplant based on purely on development of severe liver disease? I don't know that. Will biliary diversion prevent that from happening? I don't think anyone can really tell. None of our patients had progression of their liver disease when looking at things like splenomegaly, platelet ratios, or albumin platelet ratios. I think that it's very difficult to say that, okay, none of our patients progressed. Would they have progressed without a diversion? And I think that's the difficult part when you're working with small numbers of patients. And so what I would say is that we had significant improvement in growth. We had significant improvement in pruritus. And similar to the other studies, about 80% of our patients had an improvement in pruritus. There may be a decelerated disease progression. All of the patients needed vitamin supplementation, and so all patients came on vitamin supplementation. None of them really, none of the vitamin supplementation decreased. None of them particularly increased. Of interest, though, and something that you would only know if you followed patients with PFIC1, despite diversion, and I think they're starting to see this in the IBAT trials, there are patients who have issues with transient recurrent cholestasis, and it's usually associated with a subclinical illness or even a viral illness, where a patient has a mild, say, a cold, and 2 weeks later they're bilirubin, all of a sudden they become yellow again and they start to itch, and as that cold goes away, they get better, and no one can really explain why that happens. It's more of a nuisance than something severe. But if you're saying that we're going to do diversions, and if you were to say we're going to do diversions to prevent the progression of liver disease, I don't know if that particularly speaks in favor of that. It may be that, there is continued liver disease and mild illnesses bring it out. It's very difficult to really to tell. But I would say that, if you have a child that has a biliary diversion, and a year after the diversion they're doing great, all of a sudden they become itchy, and they turn a little yellow, reliably it's been completely reversible. It's not something that has caused a major issue, and it goes away in the course of weeks. What about for PFIC2 or BSEP deficiency? I think that the multi-center data it shows that it's less reliable, and so I think that if a patient has PFIC2 and they're symptomatic, and they have really bad pruritus, and they're resistant to medical therapy, I think that indeed a biliary diversion plays a role. Patients with PFIC2 tend to have more rapid progression of disease to liver transplant than patients with PFIC1. They also have a higher risk of tumor development. And why is that? Well, what is the difference between PFIC2 and 1, where there's a much more reliable response to biliary diversion with 1? Well, it seems PFIC2 is really a few different diseases. And so I don't think Jim showed this slide, but this is a great study that really shows, BSEP disease, which is PFIC2, is a few different diseases based on the mutation. And so patients that just have a set mutation are considered BSEP1. Patients who have missense mutations would be considered BSEP2. And patients that have mutations that are causing non-functional protein are considered BSEP3. And their prognosis is dramatically different, based on that. And so if you look at these numbers, patients that have BSEP disease that got diversion seem to have a slower rate of need for transplant than patients that did not get a diversion. And to confuse the issues again, when you look at the BSEP subtypes, on the left-hand side is a percent native survival, which is the opposite of the percentage of patients that needed a liver transplant. Patients that have a single mutation, at 18 years of age, only about half of them needed a liver transplant. When you look at patients that have BSEP2 and BSEP3, it's much higher risk of needing a liver transplant. On the right-hand column, it's talking about cancer risk, and this is a hepatocellular carcinoma. And so you can see patients that have BSEP1 really do quite well, do not have a huge risk of hepatocellular carcinoma. Those with BSEP2 and BSEP3 do. And so, I think it's a less reliable procedure because it's really more than one disease that has dramatically different outcomes. It may prolong native liver survival, and I would say certainly if patients have refractory pruritus, it would be a consideration. But it's not so much, it's not as set in stone as a patient that has PFIC-1. And really, you have to carefully consider diversion in patients with PFIC-2 for diversion or non-transplant surgery. When you talk about the surgical complications associated with these patients that have a biliary diversion, external biliary diversion, really two things can happen. One is more of a nuisance, is stomal prolapse, which means the inside of that intestinal layer prolapses out, kind of like a sock being turned inside out. And it's more of a nuisance. You need to do a stoma revision, and it is another surgery, but it's a minor surgery. Patients can also get peristomal hernias, and so they can get little openings in the abdominal wall next to the stoma. And these are common issues of patients that have stomas to begin with. But again, these are things that happen, less than 5% of the time. Bowel obstruction is a more concerning problem. And so anytime you do surgery on a patient and their abdomen, they can develop a bowel obstruction. And so they can get scarring inside the liver, inside the belly that causes kind of bands. The intestine can get stuck behind those bands. And with a biliary diversion, actually, the intestine can get stuck behind the piece of intestine that is used as kind of that bridge, and it can cause intestinal ischemia. And so that's kind of a more severe surgical complication associated with a biliary diversion. The medical complications that patients generally, they all have vitamin malabsorption that is similar to pre. About 50% of the patients in our series had early electrolyte disturbances, and they occurred it didn't occur early after the diversion. And so patients would generally come in, they'd get their diversion, and they were able to go home a few days after the diversion. The electrolyte disturbances didn't happen kind of until it was inconvenient for everybody. So it was about 2 weeks after, and patients would about half the patients would develop issues with acidosis, which means they would have issues with wasting of bicarb or bicarbonate in their stoma. Your bile has a fair amount of bicarbonate in it, and so patients would develop issues where they would need bicarbonate. Some of those patients actually had to be admitted to the hospital to be given IV fluid with bicarbonate and get them on the supplementation. Most of them did not, but it is kind of a consideration, and it's not something that it's not a permanent issue. Most of the patients that had diversions were on supplemental bicarb, once or twice a day, and it's an oral medication. So again, more of a nuisance. Patients, if you look at the multi-center trial, patients that had internal diversions and ileal exclusions had issues with diarrhea. And it's not surprising if you're sending bile salts to the colon and it's unprotected, it will irritate the colon, and you can get issues with kind of choleritic diarrhea. And so they develop inflammation of the bottom part of their colon, and they can have diarrhea from that. It is things that there's medications that can help with that, but again, it is a chronic problem in patients that have internal diversions, and it's been one of the reasons that we have not jumped to do internal diversions in our patients. Similarly, ileal exclusions, small numbers studied, not quite as effective, and with this complication of kind of diarrhea, is kind of one of those other things that unless you're forced to anatomically, would not necessarily do that. When you talk about the diarrhea that they get, the other thing to consider is that patients that have bile reaching their colon can actually have chronic inflammation, and anytime you get chronic inflammation, you can develop cancer. And so the long-term risk of cancer in patients that have internal diversions may indeed be higher than baseline, and it's something that should be screened for. Likewise, patients that have PFIC-2, and to a certain degree, certainly PFIC-1 also, but certainly PFIC-2 should always be screened for the development of hepatocellular carcinoma. And so as part of kind of our follow-up for patients that get diversions, we follow not only their liver numbers, but again, we try to get imaging and to look at their livers to monitor to make sure that there's no development of carcinoma. And again, if you look at the multi-center trial here, indeed, there's 2 patients who had bowel obstruction, 2 patients who had intestinal ischemia, about the same number of patients, as I kind of said, that had electrolyte disturbances and prolapse. I think the prolapse number in reality is probably a little higher with biliary diversion than 1 out of 40, but yeah, I would equate it more to like a 10% risk of prolapse in patients that have stomas with partial external biliary diversions. And so in conclusion, for non-transplant surgical management, it plays an important role in patients with PFIC. There's no question. The results certainly vary by the specific genotype or phenotype of the disease. And the partial external biliary diversion is the best studied. It may slow the progression of liver disease. It does reliably improve cholestasis and pruritus. The BSEP disease is less uniform. Diversion may prolong transplant-free survival, and certainly I would say that patients that have refractory pruritus would be considered. And then regardless of the genotype, phenotype, and the clinical results, patients need to be monitored for the development of continued liver disease, liver fibrosis, and hepatocellular carcinoma screening. And if they have an internal diversion, you need to continue to screen them for development of colorectal cancer. The complications are there. It is a rare development to develop a bowel obstruction or a serious complication. But anytime you do surgery on a patient's abdomen, it is something you have to be concerned of. And so the intestinal ischemia is the cause of the single death in a patient in the study. And I think that it is something that the intestinal ischemia from a bowel obstruction is something that you always need to think about in any patient that you do abdominal surgery on. And so, and again, the medical complications, occasional early electrolyte disturbances, they're not severe. They do oftentimes require long-term oral supplementation. And you should always be concerned that maybe the patients would need more fat-soluble vitamins than those that aren't diverted, although that really hasn't been shown. And so I think that, to say that you're on more vitamin K as opposed to, some vitamin K it's difficult to really tell how that would change things for a patient needing a diversion. And so, my next piece is on liver transplant for a PFIC. And so the first part was all non-transplant surgery in patients that have relatively preserved liver function. Liver transplant for PFIC really is reserved for patients who have end-stage liver disease. And so their disease has progressed, their liver disease has progressed to where they have cirrhosis, or they have medically and surgically intractable pruritus, or they've developed evidence of hepatocellular carcinoma. And so the post-transplant concerns between the different types of PFIC are different. We'll talk about that tomorrow. It's kind of a relatively dense subject, but I think that it's important to realize that you can't clump all PFIC into one. But I think that overall, I'm going to talk right now about kind of transplant in general for these diseases. So what's involved in a liver transplant? I can give you a brief introduction. It requires like a day-long teaching seminar for our patients, but what's involved? Well, literally you remove someone's liver, which is the largest solid organ in your body, and you take someone else's liver out, and whether the person is brain dead or a living donor, you take that liver out, you put it on ice, and then you put another person's liver into a person. And so it's not a small undertaking. It's a major surgery. It's one of the the largest surgeries that you can do. And these are kind of cartoons of the types of liver transplants. The one on the left is a whole liver, and so it's a liver transplant, say from an adult to an adult or a child to a child. The one on the right is a segment liver transplant, and so if you look at the liver on the left-hand side of the screen, the far left portion of the liver represents the entire piece of the liver that would be put in, and this is obviously a adult to say a child liver transplant. This is what it looks like in reality, and so you can see this is not a small operation. These are not small incisions, and it's something that kind of really needs to be taken into account when you're talking to somebody about liver transplant. And again, the centers that do liver transplant in children are very well versed at teaching families and even the children about the surgery and about the medical complications of the surgery. But I think it's I think this picture is great to kind of say, okay, well, indeed this is not a small surgery. And so simple question one, where do you get a liver? And so there's two sources really. One of them is deceased donors, and so these are patients that are brain dead, and so they become brain dead from head trauma or from a stroke, and you can, or any variety of reasons. But I think that you can say, well, the livers could be a pediatric size match, and so you could use a whole liver from a child into a child if they're about the same size. Or if it's an adult that is deceased, you could take a portion of their liver and put the small left portion of their liver into a child and put the right side of their liver into an adult. And so those are called technical variant grafts. Likewise, if you had somebody that was willing to donate and was otherwise healthy, you can do a living donor, and it can be adult to adult, it can be child, adult to child. And the person could be related, or they could be unrelated, or it could even be altruistic. And so we have people that want to give pieces of their liver to children or even to adults, and the recipients don't even know them. And so there does not need to be any sort of blood relation or even friend. It can be essentially an altruistic donor. Another population of patients that can give livers is what called a domino donor. And so there are specific genetic diseases that do not affect the liver, but affect the entire body. There's a disease called maple syrup urine disease that affects the body, does not affect the liver, and it is cured by liver transplant. And so you can take a liver from somebody that does not have maple syrup urine disease, put their liver into someone with maple syrup urine disease, and then take the liver that you've taken out of the person with maple syrup urine disease and put it into another person who has another disease. And so it's indeed, we've done a transplant for that involved a domino donor from a patient with maple syrup urine disease to somebody that had PFIC. And so indeed, it's not something that is unheard of, and so it's another source of donor livers. When you're talking about transplant, though, you really have to weigh out the risks and the benefits. And so, when you look at the benefits of transplant, really, you have to think about, well, what's the risk of not having a transplant? And so, on the left-hand side, you have to look at what if we continue to just do medical management. You have to look at the natural history of the disease, and what is the likelihood that this person's liver is going to get worse, or what would happen if they were a cirrhotic and they had liver failure. And so patients that have PFIC, really would only be considered for transplant when they started to have liver failure. Also, if you just continue with medical management, what's the risk of cancer? What's the quality of life of a patient that has intractable pruritus? And again, what is the mortality of medical management? How many patients that have PFIC 1 or PFIC 2, say in 15 or 20 years, are still alive? And so that's kind of the, if you didn't do a transplant, you think about the left-hand side. When you talk about liver transplant, you have to think about early issues after liver transplant. So are there surgical complications? What are they? What about medical complications? And then you have to think about late complications, because a liver transplant is not something that goes away. You have a liver transplant for life, and so there's only it's only one time, but it's something that lasts for your entire life. You need to be on medications for your entire life that you have to take, which means that you have to be adherent with those medications. And then there's disease-specific issues, and then again we'll talk about that a little bit tomorrow. But these are kind of the risks and benefits associated with liver transplant for kind of chronic liver disease. When you talk about transplant, the early things, you have to think about logistics. And so if you live away from a pediatric liver transplant center, you have to go to a liver transplant center. If you have a liver transplant, you're going to stay on average about 18 to 21 days, and so it's a prolonged hospitalization. It's about 3 months of at least weekly visits. And so if you live far away from a pediatric liver transplant center, it's a big kind of commitment, and it's a big disruption where you'd have to be in a place where you could or stay nearby your pediatric liver transplant center. And again, there's multiple medications, and so there's no doubt that patients after liver transplant are on more medications than patients that have PFIC. And so the early medical complications, you talk about complications of the medicines that we use to prevent rejection. And so these oftentimes cause issues with hypertension. It can cause renal issues. It can cause issues with seizures if the levels are very high. It can cause transient diabetes. These medications can also frequently cause electrolyte disturbances. And again, these are all things that are early after transplant, but something that kind of has to enter into the risk and benefit. The other thing you have to think about are, pre-existing medical issues. You have to think about pain management and nutrition. Patients that have PFIC-1 certainly, and even, the other types of PFIC have issues with nutrition. And so to undergo major surgery does require a lot of nutrition to heal. And it is a concern that we have both before and after transplant. Rejection is commonly thought about when you have a liver transplant, but it's not something in reality that is a huge kind of graft or life-threatening problem. And so rejection happens about 30% of the time after a liver transplant. And they're correctable by changing medications around. Sometimes patients require rehospitalization. The risk is lifelong, but the risk of rejection is highest in the first 6 months after transplant. And so when patients reject, they oftentimes get readmitted to the hospital. They get put on higher doses of immunosuppressive drugs, and then they're followed closely afterwards. But it's not unlike heart transplant, where rejection can really lead to the death of the patient and death of the organ. Liver transplant rejection is a much different process. What about surgical complications? Well, we're not perfect, right? And so again, it's not a small operation. And so any one of the things that we do can have issues along with it. And so the routine things that we think about after transplant, abdominal closure. And so, I think that when you take a piece of an adult liver and put it into a small child, or even when you take a child's liver and put it into another child, they may not be exactly size matched. And so some patients require delayed closure, and so they require operations after the transplant to close the belly. Every time you do surgery, you worry about infections, you worry about bleeding. Liver transplant has come a long way in the past 20 years, and we oftentimes do transplants without needing any blood. But there is a risk of bleeding, and it happens about 1 to 5% of the time after a transplant. Infections, bacterial infections, bile is not a clean substance, and when you do a liver transplant for a period of time, there's bile leaking out of the liver into the abdomen, and so that it's not a clean case. Liver infections do occur. Fortunately, it's not often, and so only a few percent of the patients that have a liver transplant get any type of bacterial infection. But it is something, again, to be concerned about. It's something to think about. Transplant specific problems. So anytime you sew a blood vessel to another blood vessel, it can narrow, it can clot. All of these things can lead to issues with the graft. It can lead to severe problems. And so hepatic artery, which is a small artery that goes into the liver, it can have issues of stenosis or thrombosis nationally about 5 to 10% of the time. It's not quite as high in areas or in centers that do a lot of the transplants, but it is something that certainly is concerning. It's something that can cause the graft to fail, and something that we spend a lot of time and a lot of effort trying to prevent. But it certainly is something that can happen. On the other side, that dark blue arrow is the hepatic vein. That's where the liver empties, and so that can be narrowed or thrombosed about 1 to 3% of the time. Similarly, the portal vein, which is the vein that brings blood flow in to the liver, can narrow. And again, it's rare, but it happens. Bile ducts, when the liver does all of its magic and it processes things, and all of the bile salts that are built up in your blood get expelled through the bile duct, they have to go through that bile duct into the intestine, and that can get narrowed. And it happens about 10% of the time. bile duct issues are more commonly handled without needing reoperations, but it certainly can lead to another operation. But it happens about 10% of the time after a liver transplant in a child. When you look overall at the number of complications, I think it's it's impressive to say, well, gee, why would I even do a liver transplant? But these obviously don't happen all the time. These happen in the 5 to 10% range, and these are things that certainly enter into the risk and benefit ratio of a liver transplant. How can we improve it? When you look at why patients die in the first year after transplant, even though it's a very rare event, the things that we can improve upon are things like infections, issues with unrecognized cardiac issues, issues with primary non-function, which is not something that generally occurs in pediatric liver transplant. And then again, the hepatic artery thrombosis is something that that we spend a lot of time and again a lot of effort trying to prevent. If you talk about graft loss and you say, what causes patients to lose their liver and get another transplant, or what causes patients the need to get another transplant, hepatic artery thrombosis again is something that is there, and portal vein thrombosis is another thing that we tend to really spend a lot of time trying to prevent. And again, this is data that's from around the country from a long period of time, and these rates are high compared to centers that do a lot of transplants, but it is something that you always have to think about, and always something that you have to worry about when you're considering liver transplant. And so in summary, the short-term results of patients that get liver transplant are excellent. And so, there's no question that, I don't mean to say that liver transplant is a horrible thing, but, I think that 95% of the children that get a liver transplant in general are alive and well at 1 year. But, despite this, it's a major procedure, and there are complications that occur. They occur not infrequently. They're not usually graft or life-threatening, but it is something, again, to consider that in a patient that needs a liver transplant. What about late issues? And my child has had a transplant. They're doing well. They're 1 year out from their transplant. What is the likelihood they're going to live a normal life? We say that you get a liver for life, and our results actually would say that. And so if you look at our 10-year or 12-year survival, about 90% of the patients are alive and well 12 years after their transplant. There is multi-center data out there about patients who have lived their first year after transplant, and what causes them to die after that. And so if you look at patients, if you look at the curve on the right-hand side of the screen, these are all patients that are alive 1 year after transplant. And as you can see, if you live your first year, there's about 94% of the patients are still alive at their 5th year. And if you look at the graft, that's the liver, 90% of the grafts are still there, which means that 10% of these, require a retransplant. A lot of times the interesting thing is in the space between. And so, what is, although this is a very small number of patients, what caused patients to die, or what caused patients to lose their graft after surviving the first year? And so if you look at what caused patients to die and what caused patients to lose their graft, the left-hand side, well, most of these issues would be suggested that maybe there was too much immunosuppression given, and so you have a patient that has just been getting too much immunosuppression, and they develop an infection, a recurrent malignancy, lymphoma, which we'll talk about in a little bit. These are all things that are directly tied into immunosuppression and the drugs we use to prevent rejection. Unfortunately, the grafts that are lost, and again, the numbers are small. These are 34 grafts out of 1,600, and 34 patients out of 1,600. The numbers are very small, but if you look at the graft loss, most of them are due to too little immunosuppression. And so it's the balance between the two, and the lifelong commitment to kind of that balance that really allows patients to live normal lives, 20, 30, 40 years after liver transplant. What about the other. And so I don't want to talk about, alive and dead. It's important to talk about, how well patients are after their transplant. And again, this is a multi-center group that looked at transplants that were done. 15% of the patients were living donors, 85% were deceased. And, interestingly, a lot of the patients that received transplants received either portions of adult livers or living donor grafts. And so it's an important component. But if you look at their long-term survival and their long-term issues with medical complications of liver transplant, 9% of the patients had some degree of renal insufficiency, and this was purely by numbers. This is not this is not a patient who needs dialysis. None of these patients needed dialysis, but these patients had, if you looked at very specific studies of their kidney function, they had not normal kidney function after liver transplant. 5% developed a disease called PTLD that I'll talk about in a second. Overweight, about 10% of the patients were overweight, which is higher than the general population. 23% of the patients were smaller than general. And again, some of this is in relation to their pre-existing disease. And so if you said these are patients that have had PFIC, most of the patients were small, most of the patients are short. And so that it wouldn't be surprising that many patients would remain short and small. Hyperlipidemia was a major problem, and patients who required medications for glucose control were also relatively high and higher than one would expect. And those are likely direct complications of steroids and even Prograf to a certain extent, which is the two most common drugs that we use to prevent rejection. I couldn't do a transplant lecture without talking about PTLD. PTLD is post-transplant lymphoproliferative disorder. It's caused by Epstein-Barr virus. Epstein-Barr virus is a very common virus in the United States. About 80% of the population has had an Epstein-Barr virus infection by the time they're an adult. If anyone here has ever had an Epstein-Barr virus infection that has been symptomatic, it's called infectious mononucleosis. And so you end up with big glands, they say, or big lymph nodes all over your body. Sometimes your spleen can hurt. And what that response is, and what infectious mononucleosis is not the virus itself. It's the body's response to the virus. Unfortunately, if you develop a Epstein-Barr virus infection while you have immunosuppression on board, your body does not respond like that. And although you're spared the torture of mononucleosis, you end up with Epstein-Barr virus viremia, which means the virus continues to kind of proliferate inside the cells in your body. Epstein-Barr virus lives in cells called B cells, which are a type of lymphocyte. And so having just viremia, we can check now the amount of virus in your blood, just like you check for COVID. You can check for EBV by PCR. And patients can develop EBV viremia, and if it's just that, it's not a major problem. If it's not recognized, if a patient doesn't get the EBV PCR checked, or if they develop, say, rejection at the same time and you have to increase the immunosuppression, the Epstein-Barr virus can then cause invasive disease. And so you can end up with Epstein-Barr virus hepatitis, or Epstein-Barr virus enteritis, or tonsillitis, or any itis that you could really come up with. And so if that is left unchecked, it can become post-transplant lymphoproliferative disorder. So there's many steps along the way that these things can be prevented. Despite that, and despite the ability to check Epstein-Barr virus in the blood, about 5% of the patients that get a liver transplant can develop PTLD. And of that 5%, about 10% can be fatal. There's many drugs that are available. The primary treatment for PTLD is reduction of immunosuppression, but there are drugs available that specifically treat these tumors. But despite all of that, despite recognition and everything, about 5% countrywide of patients that get a liver transplant will develop some PTLD. And again, most of them are completely treated. And so, summary of transplant late, multiple studies have shown great survival, both short and long term. But despite that, transplant is not a small undertaking, and it should really be reserved for patients who have advanced liver disease and other really severe complications of PFIC. And so it's not something that would be kind of considered early. And again, the disease, the disease process itself, the type of PFIC and its response to transplant, we'll talk about tomorrow. not today, just to avoid, an extra dense discussion. And so that's the end of the surgical talk. And I'd be happy again to answer any questions that you guys can come up with.
Thanks, Dr. Soltys. That was really great. That was very informative. And I think you really honed in on, transplant is not a cure. It's an option. It's a back pocket option, and it happens with a lot of our patients, my daughter included, but it is absolutely not a cure for PFIC.
Absolutely.
Okay, so we do have a few live questions. We have hit the time, but if it's okay, I'd like to at least go for about 10 minutes, 10, 15 minutes while we have the attendees now. And then we'll have some questions to roll over for tomorrow, since we'll have you both here on the call tomorrow. Do you have about 10, 15 minutes that you could spare for our audience?
Oh yeah, sure, absolutely.
Okay, great. Okay, so I'll tackle these live questions first, and then, like I said, I'll roll some of them over to tomorrow. Okay, so regarding external diversion, and this one's specifically the drugs that are in development versus diversion therapy. So does maralixibat do essentially the same thing as external diversion? And if so, why are the results effective for PFIC2 patients taking maralixibat and yet not as predictably effective when having an external diversion?
Yeah, I'll see if Jim has more to this, but I think that, again, the number of patients that have these diseases is so low that it's going to be hard to really hone down a result. To confound PFIC2 even more is the idea that there's more than one subtype, and so I think that it may work great for patients that have BSEP1, while there's another population of patients it does not. And so I think that does certainly explain some of that. And again, I don't think that biliary diversion is wrong for a patient that has BSEP disease, but I think that going into it, I would not say, hey, there's a 90% chance or an 80% chance that the pruritus is going to go away. Nor would I say to a person with BSEP disease that their liver disease won't progress. I don't think there's as much data. And I would say the same for the IBAT inhibitors. I think that the results probably long term are not going to be as good for BSEP disease, all types, as it would be for PFIC1.
Okay, great. And we can talk about that a little bit more tomorrow, maybe when Dr. Squires is on the call as well. I can bring that one back up. In regards to liver transplant, do you have any long-term success rates of grafts? Because according to what we can see as patients, what seems documented is about a 20 to 30 year post-transplant success rate.
Yeah, so I think that transplant's hasn't been around that long, so that's about what we have. I mean, I think that there's really good data at 10 years. There's very good data at 20, and then after that, I don't think that there's really solid data. We know patients that are 30 years out from transplant, but I think that as opposed to now, where survival is the expected outcome of liver transplant. When you're talking about our 1 year survival here is it vacillates depending on what diseases we're transplanting in a particular year, but we oftentimes have 100% 1 year survival, as opposed to in the past where survivals really were 30-40%. And so I think that there's not a lot of people out there that were transplanted 30-40 years ago. And I think that's changed. I know that's changed because the number of patients in the country that are 10 years out from transplant is there's a huge number of patients. And if you can extrapolate 5-year and 10-year data and say, hey, what's going to change from year 10 to year 20, I suspect not much. And so I think that there's going to be a lot of 20, 30 or 40 year survivors. It's just a matter of the time for that to happen.
Okay. In follow up to that, along the transplant lines, when talking about living donation versus cadaver donation, I know that there's some debate about, because there's the genetic component of this disease. So with living donation, has there been any further data about whether living related donors are a good option for our patients, or how I guess this is a separate question, but living donation versus cadaver donation, what the, is there a more positive outcome in one versus the other?
Yeah, so even if you look at, take PFIC out of the question, is survival after living donor better than survival after, deceased donor? And the answer is no. Survival in centers that, and again, we're talking about pediatrics, in centers that do a lot of pediatric liver transplant, the survival is the same, whether you use a deceased donor split, a deceased donor whole, or living donor, or domino for that matter. And so I think that the results are exactly the same, across all of those. The nice thing about living donation, and one of the things that probably skewed the early results of living donation, is that you can do the procedure when you want to do it. And so if you looked at survival rates early on, say 20 years ago or 15 years ago of living donor, they were better because patients were being transplanted oftentimes before they got sick. And so the results were overall better. And I think that plays the same for PFIC, and it plays the same for now. If you have a living donor that is otherwise healthy, I think that the advantage is that you can do it when you can do it.
Okay. Circling back to diversion, are there any thoughts on reversing an external diversion, as a child gets over for vanity reasons, versus going with the internal?
Yeah, I think that that is, we've actually talked to patients about that, and I think that the data is not clear, and I think as long as they're okay with being screened for colorectal cancer, and they're okay with the idea that they may end up with diarrhea, then I think it's an acceptable option. At the same time, the thing I worry about is the ability to go internal. If it were to not work, could you then go back to external? And that may be a little bit trickier. And so we haven't done it. And as far as I know, no one's had to do it. But I think that it is something that as long as everyone is on the same page about it, I would be okay doing it.
I guess kind of in follow up to that, does multiple surgeries, if you did go down that course, does multiple surgeries like that lead to scar tissue? And then if you were to need to do a transplant later on, does that become a barrier to doing transplant?
Yeah, I wouldn't. No, I wouldn't worry about that. I think that although yes, it does make it slightly hard, or it makes it 1% harder or something like it. Once you do that, I would not discourage someone from doing a diversion for concern of need for transplant in the future, nor would I really say, hey, you shouldn't try to reverse it or have other surgery if it offered the chance of prolonging surgery or prolonging a transplant. And then we'll talk about diversion after transplant tomorrow too. That's another topic that.
And I think you can expect quite a few questions related to that tomorrow.
When we do the diversions, we intentionally try to leave it. I try to leave as much extra as possible, just in case somebody, the intestine that we use. When you first start thinking about doing diversions, you say, well, I'm going to leave the intestine very short. But when you start thinking about long-term issues where you might have to go back and revise it or make it internal, or that type of thing, it lets you plan surgically what you would want to do. And we try to leave enough so where if somebody were to do an internal diversion after an external and then have to go back, they would have enough intestine. So it's a point well taken, and it's something that we've learned over time.
Okay, that's interesting. Going back to a transplant and PFIC2, so you both had mentioned the risk of cancer is elevated in PFIC2. Is that also a higher risk even for PFIC2 patients who are post-transplant? No,
that risk goes away, with the liver, and so it's not something that that I would worry about. PFIC2 has its own issue after transplant, and I'll do a teaser for tomorrow. No, PFIC2 does have an issue in that the protein that has the mutation in it for PFIC2 or BSEP disease is actually on the outside of the cell, and patients that have liver transplant have actually had recurrence of their disease. They call it. It's essentially they attack the the protein that's on the outside of the cell. And so they can have an issue where they have essentially a rejection of that molecule on the outside of the cell, and they can have recurrent disease, which can be somewhat hard to treat, and also can come back even if you do another transplant. And so it is a unique issue with BSEP disease.
Yeah, and we do plan to pick your brain about that tomorrow as well. So I'm glad you brought that up.
That's it. That's all I got. That was my only brain. It's as deep as my brain goes. I'm just kidding. No, we can talk about it.
Your moderator happens to experience that, so get ready for that.
Interesting.
No, okay. Let's do so one more live one that came in, and then one other if we have time. And this might be more appropriate for Dr. Squires, but maybe you can touch on it. It's about FibroScan as an accurate way of determining liver health. It's used for one of our attendees, and just wondering like the reliability in using it, or what are the pros and cons?
Yep. Yeah. Data is accumulating for pediatrics. I think that there's many different ways to do FibroScan, or I would say that the easiest thing for a patient that has PFIC is that yes, you can do FibroScan on an annual basis, or every other year, and you can follow the trend. An absolute number is a little bit trickier to really figure out what to do with, and so year to year you would follow the trend. What you do with that, I don't know. And so if you have a patient that has PFIC and you notice that their FibroScan is getting worse, there's not particularly a treatment for that. And so it's kind of one of those things that you would put into the piece of knowledge that you have, or the bucket of knowledge that you have about that person's liver. Because we really screen patients for hepatocellular carcinoma, I think that the other option is MRI, and MRI is actually a really good way to screen for the development of liver tumors as well as cirrhosis. And so you can kind of combine those two modalities and really get a more kind of solid answer.
Okay. Great. And one last question, kind of more related to diversion, and the rest I think we can talk about tomorrow. So you talked about diversion and kind of management and nutrition management, and it has some effects, kind of longer term. What about vitamin deficiencies specifically related to transplant, both external and internal?
Yeah, so we thought they would be much worse. I have to say is that, when we started to do diversions, however many years ago that was, we really, everyone kind of thought that the vitamin deficiencies would be a major issue, and they are. There's no question, but we've not had anybody that has really had a major complication of their vitamin deficiency. They're on multiple and very high doses of vitamins, but unfortunately, it's part of the disease process. Sometimes we get vitamin deficiencies in patients that have liver transplant that don't have PFIC. And one of the ways that you can ameliorate that, if they have bile that's diverted out, one of the ways you can ameliorate that is to refeed their bile. You give them bile back along with vitamins. In patients with PFIC, it would be kind of defeating the purpose. And so you can't really do that. And so on a good note, we haven't had any huge complications of the vitamin deficiencies. There was a lot of concern about vitamin K, which is, affects your clotting abilities. And there's a pre-vitamin K, a PFIC, that they have, that we were very concerned about having issues after diversion. And fortunately, I'm going to knock on the nearest wood I have. It has not been a major issue. And a nice way to monitor vitamin levels, besides measuring them, actually, is to just check someone's clotting factors, or INR, and you can actually see what their kind of the likelihood that they have vitamin issues is. If the vitamin K and their INR is normal, chances are you're absorbing a fair amount of your fat soluble vitamins. Okay,
great, that's helpful. There is one more. I'm not sure if this is better for you or for Dr. Squires, but do you have any experience with hyperbaric treatment, and or have considered using it for your patients, or know of any studies using it?
We have not.
Okay.
Yeah, hyperbaric. I have not. Jim might, but I don't think any of us have used hyperbaric. So okay. I've used hyperbaric for patients that have had hepatic artery thrombosis in the past, but I've never used it for PFIC.
Okay, great. And maybe we can ask tomorrow when Dr. Squires is on. But,
yeah, sure.
Yeah, so I think we can kind of wrap up there. Most people who attended today, hopefully you'll be able to attend tomorrow and we can finish the Q&A and learn more about the transplant related complications and then life after transplant. But this was really great. We really, really appreciate both you and Dr. Squires taking the time to put together these presentations.
Yeah.
I think you've both done a wonderful job.
Absolute pleasure. Yeah, thank you so much for the invite. Again, this has been we have a lot of patients that have PFIC, and we have a lot of connections with all sorts of physicians who have this. So it's a very pleasurable and kind of nice talk. It's an interesting disease, and the patients that we've experienced have been actually more educational than anyone else. So thanks for the opportunity.
Yeah, absolutely. Well, we look forward to speaking with you tomorrow.
All right, I'll see you tomorrow.
All right, thanks. And I guess for anybody who's still on, if you have any questions that are lingering that you want to ask tomorrow, or if you can't join us tomorrow, but you'd like to ask, these sessions are going to be recorded. So you could send me an email, emily@pfic.org, and I'd be happy to ask the questions on your behalf. And I can even email you back an answer. But we hope that you guys can join us tomorrow for further discussion. Thanks everybody for joining.